knowledge on a global scale, while also giving you the possibility to actively participate in the discussion via our chat function. So please feel free to send over any questions or put your comments in the chat or the Q&A, and our great experts will be happy to answer you. MOH, or the Medical Online Hub, is actually bringing together the medical expertise from around the world to discuss state-of-the-art topics in the field of the veno-lymphatic disorders. So today, we have a top-notch experts from Egypt, also from Germany, with us to bring their expertise to you. On a personal note, I'm really looking forward to this event and some very dynamic, lively discussion, and I wish you all a wonderful and a fun time during this MOH. Having said that, I will have the pleasure to introduce our main principal moderator and also our expert speaker together. So first, I would like to warm welcome Dr. Wasila Taha. Dr. Wasila Taha is like well-known expert. It's really hard to find the words to start with, but as we call her the Cleopatra of the veno-lymphatic world, she's more from Egypt. She's the General Secretary of EVALA, the Egypt Africa Venous Lymphatic Association, with a great event happening every year in Egypt. Also, she's a consultant, of course, in vascular medicine and geologist. More than 25 years of experience in vascular ultrasound. I'm sure that you have seen her in different successful workshops all over the world. She's the chef of the TDC, the Duplex Center, and also co-director of the Vein Clinic of Egypt. She's the fellow of CHU, the Center Hospitalier of Liege, Belgium, and also a member of the ARDMS, the American Registered Diagnostic Sonography. She is also international ambassador for Africa at the AVF, the American Venous Forum, and she is also continental chair of NINA, or Near East and North Africa, at AVLS, the American Venous Lymphatic Association. She's also a member of the famous UIB, the United International of Phlebology, in the Educational Committee. She's a lecturer in many courses in Egyptian Vascular Fellowship. She has a great contribution in the national and international vascular conferences and congresses everywhere, and she received a lot of awards. One of them is Best Submitted Abstract in the UIB chapter meeting in Krakow, Poland. It was really a big success in 2019. And she is also the inventor of the ABSV, the ankle peak systolic velocity, a parameter to assess different degree of peripheral ischemia. I can continue more and more, but I think we need another 15 minutes to continue introducing Dr. Wasila Taha with her great contribution to the medical and the veno-lymphatic community.
Thank you so much. I feel speechless, Mahmoud. I have never been introduced in such way. Thank you. Thank you so much. Thank you.
Yeah, of course. It's really our pleasure and honor to have you, Dr. Wasila, with us.
Thank you.
And now I will also introduce Dr. Erica Mendoza, which I have the honor and the pleasure to be again in her clinic. Of course, Dr. Erica Mendoza, I need also another 15 minutes to introduce her. She is specialized in the venous investigation, duplex ultrasound, and treatment with preservation of the saphenous trunk, JIVA, CHIVA, with the vein office in Wonostorf, where I'm now with her in the clinic. Again, thanks so much for inviting and having us with you. She has running this since 1997. She's authored books in duplex ultrasound. I can see here in the background of her library a lot of really great achievement, great references, books, studies, research that she has done in the duplex ultrasound. She has also her own courses online and offline. It's really a great contribution to the community. She is also having different courses in different languages. So she speaks, I think, if I'm not mistaken, 7 languages, I guess.
Oh.
German, English, French, Italian, Spanish. So you name it. She provides a lot of lectures and hands-on workshop in Germany, but also in the international meetings. She's now the General Secretary of the German Society of Phlebology since 2015 and the current president of the EVF, or the last EVF, president of the German Phlebology and Lymphosis Society meeting in 2022, also the president of the EVF meeting in 2023, Berlin, president of the German Society of Shiva since 2000, and the member of Educational Committee UIB since 2023. As I said, I can continue again and again introducing Dr. Erika Mendoza, but really, I'm honored and also feeling really delighted to share the stage with two of my own models, Dr. Wasila Taha from Egypt, my home country, something I'm really super proud of, but also with Dr. Erika Mendoza in her clinic. So with that, I would like to hand over to you, Dr. Erika, to start your presentation.
So thank you so much. And I think Vasila and me are very honored to have you with us that initiate this MOH thing. And I thank you personally because when I told you, oh, it's always talking, why don't you do hands-on? You immediately said, yes, we'll do it. And I hope that this will be a model to spread over the world because I think lots of people have things to show. So let us start with a little introduction. I don't know, Vasila, do you want to say something or later on?
Yes. I beg your pardon, Erika?
Do you want to say something now or just when I finish my talk?
Yeah, no, ma'am. I'm just, I echo what you said, that I'm truly honored being with us with the MOH for the first time. I found it's a wonderful idea to change the platform from just lectures and online lectures to a real ground with the hands-on workshops. This is really a genius idea. I really appreciate this and I congratulate this idea. Thank you.
Thank you. So I hope I had an issue with the patients. Things have changed. I don't know if everybody has perforating ways to show, but I hope this will be the case. So I will start with my little short presentation. Everybody sees it, yes? Okay, about ultrasound diagnostics of perforating veins, which is supported by Sigvaris, as you all know. So perforating veins, we know they had own names like DOT in the middle and upper thigh and Hunter on the adductoric channel, which now they are called medial perforating veins at the thigh and at the adductor channel and proximal paratibial vein void. These ones are often involved as a source of reflux. And then we have lots of perforating veins on the calf, like on the inner part and on the back part of the calf. Unlike the ultrasound investigation, you know there are perforating veins here, but they are not uncovered by the liquid, the contrast media, because they are not involved in recirculation. So we only have to investigate the perforating veins that are enlarged and will be obvious to our eyes. And the question, when I started 20 years ago, often it was discussed, all the dilated perforating veins are pathological. And I kept fighting and saying, no, only those with a diastolic outflow are pathologic, because if you have an enlarged vein, like a very large vein, the blood that will drain through the perforating veins will enlarge also the perforating veins secondarily, but they are not primarily ill. So you see, this is the tibial bone, you see that perforating veins can be enlarged but draining, and this is very, very important to have in mind. So what do I mean when I say systole and diastole? Systole in the leg is when we make a muscle pump or we compress the calf so the blood goes up to the heart, and then we wait what happens in the deep and in the superficial vein, looking at the flow in the perforating vein. And if in the diastole, the blood goes down through a varicose vein or through a healthy vein and drain to the deep vein system, we have an inflow to the deep vein. And this is the phase, the diastole, when we have to look the flow of the vein to determine if it is refluxive or not. You see here a very large vein at the calf with a large varicose vein draining here. In systole and diastole, you have a draining flow. So this is obviously a large vein, but it is not a pathological vein. Other thing is this. This vein is also a tibial bone. This is a person that had a deep vein thrombosis, and you have an obvious outflow through the perforating vein in diastole. So this vein is really pathological, feeding the superficial recirculation. The same, this one, we have a great saphenous vein longitudinally. This one is the way to the thigh, and this one is the way to the knee. And here we have a competent part of the vein. Here we have a refluxing part of the vein. And here we have a dot or a medial perforator of the thigh with a large reflux volume filling the great saphenous vein to the knee. So sometimes perforating veins are the reason of the varicose veins, and mostly these are located at the thigh and not at the calf. One very important thing is when we have occlusion of the deep vein, perforating veins may help to find a bypass for the blood, to help it go upstairs, as I always say, to the heart. So we find the deep vein occluded, and then we have a systolic and diastolic outflow here, and a flow, an anterograde maximum flow in the great saphenous vein. You see here the great saphenous vein coming from the foot, which is tiny. Then we have the void or the paratibial perforating vein below the knee, draining the blood from the deep veins to the superficial one and filling this very enlarged great saphenous vein, bringing the blood upstairs. And here you see the classical thing, perforating vein in the knee fold. The saphenopopitial junction is this one, which is healthy. The saphena parva, you will see it here, little there. It's completely, the small saphenous vein is completely healthy, but you have a permanent retrograde flow in diastole. You wait, this is systole, this, and then in the diastole we have a long-lasting outflow in the perforating vein in the fossa poplitea. A very strange and not so often to be seen perforating vein is a so-called transtibial vein, which happens after a bone lesion. Like here, you see that the tibial bone is disconnected here, and then you have an outflow from this. And I only can invite you to our next MOH, which will be Saturday, 21st of September, because I will make a foam sclerotherapy of this guy with this paratibial perforating vein. So everybody, please have a look at the calendar of the MOH. This is an interesting thing. Just to summarize, re-entry perforating veins are always competent in systole and in diastole. If the perforating vein is enlarged, we will have an outflow in systole, but the diastole, when we release the calf of the patient has lowered the toe, will be into the leg, to the deep vein. And if it is an escape point in the diastole, we will have a reflux. And I think we will have the occasion to see some of these cases this evening. We have a little bit of seasonal flu in this time, and I didn't phone one of the patients. I hope everybody is coming, and so I hope we will have full session. Just to remember, this is a paratibial perforating vein, and you see obviously much longer than 1 second. These are lots of seconds, 5 seconds of reflux through this perforating vein. In that case, it is obvious you have a reflux. Okay, so in summary, you find perforating veins widened along the varicose veins. You investigate, and you only have to investigate those that are really widened. And the important phase to determine the reflux is the diastole, and the diastolic drainage through a perforating vein often marks the distal re-entry point of a varicose vein. The dilation of the perforator depends on the amount of reflux, and if it is a draining perforating vein, if you put out the reflux, like with involuminal laser therapy or heating occlusion or foaming stir or operating, however you close the reflux, the perforator will again get closer and you won't see it anymore. The reflux in systole is seldom, and if you see it, you have to think of a problem with the deep veins. So this was a small introduction, and I would like you to make the first poll questions. I have to change a little bit the settings, so I will leave the place, and Vasila is there for questions and for
Thank you so much. Yeah, thank you so much, Erika. It was an excellent introduction for such an important item in our specialty for the perforator veins. And as you mentioned, very clearly that they are not just a vein. No, it is very important to diagnose is that a simple re-entry perforating vein or a pathological incompetent perforating vein, which really dramatically change our line of treatment. It's perfectly well mentioned. And if we have some time, we can see the history or the saga of such perforating vein by the anatomist first mentioned. Now we have the poll. Okay, thank you, Khalid. I'm not sure if everyone can see the poll questions. Mahmoud, everyone can see it now?
Yeah, I think now it's
okay.
visible, and we'll just
So,
give like 30 seconds.
So the first poll. So the first poll, perforating veins are always part of the recirculation pathway in varicose veins. Which answer is wrong? Number one, a dilated perforating vein is always causing the reflux in varicose veins. Number two, for the diagnostics of pathology in perforating veins, the interesting phase is the muscle diastole. And number three, a draining perforating vein is defined as having flow from superficial to deep during diastole. We have 1 minute to have the results of such voting. Please vote.
Thanks so much, Dr. Wasila, for sharing the poll questions. So now we got the patient in the clinic, and as you can see, we have a special setup in the clinic, which I think can really help so many of vascular surgeons, how they can set up their clinic to get a different perspective when they are investigating the patient.
I like the way, because there is a step, and now we have the results of the poll. A dilated perforating vein is always causing the reflux, with 62% for the diagnostic of pathology in perforating vein, 21. A draining perforating vein is defined as having flow 80%.
So
you did a great job, Eric.
I hope, yes, but yes, which is wrong. Yes, okay. I hope yet after
61,
at the end.
21.
So the first patient is here, and so I would like to start doing the investigation, if that is okay. Everybody
can
fine with it, so I will share my screen again. I hope it will run like it did earlier.
I like the setup. So it's very important to see that the machine of the ultrasound is on the right side of the patient bed. This is very important. And in the level, very comfortable to the operator, so he can do the provocative maneuvers much in a comfortable way, I mean. So your setup, it's very well done, Eric.
Thank you. I think so, because I'm only doing this. And of course, we have lost our, we saw everything
now we have it
earlier, and of course I've lost my computer. Just like give me 2 seconds to find again my laptop. I have a ball. Perhaps you can see on the image. I have a ball on which I'm sitting, because this helps me not to get my back stiff. And so
can we see the ball? Could you focus on the ball where you sit?
And another thing which is
yes.
I have a second screen here, so that when I make the ultrasound, I don't have to be like always looking to the other side, but I can look to the leg and have the second screen behind the leg. This is good for my neck. And now still I have to find.
Perfect.
I have to connect.
So what is the way when you start? You start from the back with the small saphenous vein, or you start with the great saphenous vein? What is your way to scan the patient?
Yes. Usually I start at the groin, but in this case, no. Do you see the image? No, you don't see the image. Isn't it true?
No.
I share it now. Share. Where are you? Here. Do you see?
Could you
now?
explain us the clinical of the patient, of your
Yes.
patient, Erica?
I will
The
start
clinical
the second
manifestation of the patient.
First, thank you.
Now we can see the ultrasound screen. Yes.
Yes.
But a little bit about the history and the clinical manifestation of your patient, please.
I have seen this patient many years ago when he had a muscle vein thrombosis in the left calf, and we treated it with anticoagulation and compression. Then we did an interruption of the tributary because this was having a varicose vein here. And today he came back after lots of years and asked me because he has new varicose veins in the back. Und Sie haben auch Schirm umdrehen? Ja. Manu, einmal ganz umdrehen. Noch weiter umdrehen. I will put the slide on. I have an extra light here. Können Sie noch mal ein bisschen weiter drehen? Nee, in eine andere Richtung. Okay. Come here because light is better here. And you'll see here some days. It is not so. No, are you filming? Does somebody see what? Yes. Here you see there. You see some days. This is not very horrible, but when you look at
We see it on Mahmoud's screen. Yes, we can see it.
Mahmoud's screen, yes. If you think like, oh my God, this is not so horrible. What is she doing? But when you see the inside pictures, you will understand what I'm doing and proposing. And the guy notices like something is happening here when he sits down. He has like a pressure, and after a long day, he has also pressure. He has come very early, so there is no skin discoloration or nothing. He has no edema. But as he already had thrombosis, he wanted to get sorted the problem early. And he was very spontaneous because this morning somebody said he can't come and he just stepped in. So thank you so much. This one is for you back. And so I will, in this time, I will show you because you asked, because you asked how I usually start the investigation. We did this another time and we can repeat. Usually I start on the groin on the right side, always the same. Yes, I have the correct preset. And
so you are on a venous setup, please.
Yes.
We can see LEV. So it's a very first you have to select the appropriate setup.
Yes.
This is very important for the beginners.
Yes. And sometimes
I can see on your screen. So lower extremity vein setup. So you have the appropriate setup for the venous scanning. We can see now the common femoral vein. Yeah.
You see the common femoral vein here, the artery, and the saphenous vein. It's like the Mickey Mouse. You all.
Yes, the Mickey Mouse sign. Yeah.
We can put the color inside, and we can put the
artery pulse style. Perfect. Yeah.
Just to say, okay, the guy is alive.
Triphasic waveform. Yeah.
Yes. The next thing that is to sort out that there is no thrombus in the deep vein, which you do like compressing. Yes. You can do this in supine position or in standing position, but this is the demonstration that there is no, okay, I have to put documentation. There is no thrombosis in the deep vein. Then I investigate the saphenofemoral junction, which is this one. And I have always to make
sure. So you start first with the B mode, Erica. No color at the first. You start with the B mode. You identify your vein, your common femoral artery, common femoral vein, the junction, the great saphenous. And then you put your color box.
Yes.
All right.
You see in the longitudinal, you see the valve.
Yes, you can see the epigastric vein perfectly well with the great saphenous, the junction, the terminal valve is very well seen. Yeah.
You see a wonderful thing, which I didn't expect us to have here. This one is the drain from the epigastric vein into the deep vein.
Yeah.
So yes, a flow from the epigastric vein. This is sludge in the saphenous vein. Is that visible in your display also? This one, you see, Okay.
For
the mobile phone in the back. So then I go back to horizontal view. And you see, I make a compression of the calf. And there is this artery crossing, which is always disturbing when you do operation. And you see a little bit of inflow from the deep vein to the superficial, from the superficial to the deep vein.
Yeah.
But there is no reflux. Hier ist mal jetzt hier Schulterflut, einmal und wieder runter.
There is no reflux from the deep system, right, Erika?
No reflux from the deep system, no. And then now we
From
go,
the deep system, there is no reflux.
you go down and we have the following. I go down looking at the great saphenous vein. You know this Egyptian eye here, saphenous.
Yes.
Fascia
Yes.
saphena, fascia muscular.
Can you go much more for the depth?
More
For the depth?
or less?
Less deeper, maybe?
So like this. Is that fine?
Yeah, it's perfectly seen now, yeah. The saphenous eye or the Egyptian eye, yes.
This is the, you look, I have the probe
Perfect.
into the skin. You can see that the magnet iPhone, yes. Oh, it was not allowed to say the model. So now I put the PW and to have a good image, I tilt the probe. I don't do it horizontally, but I tilt it a little bit to get a better information. I make a calf compression, and there is nearly no flow in the saphenous vein. So the next one, we make a toe elevation, yes, and and there is nearly no flow. But the patient has some tributaries, very little ones. And so we will make the thing I've already done other times. Lege ich mal hin. The patient is recumbent, yeah, and he will lift his leg up. We wait some seconds, and you will be surprised what happens then. Just a moment.
So you mean before this maneuver, you had no reflux, and when you ask your patient to lie down and then hop in the same level, you recheck for the reflux, and you have now a very long reflux.
Yes, but it isn't normal. I didn't find.
Erika, where you want to recheck? Put a mark by the pen.
I will, yes, I will just,
Okay.
just talking and I'm understand. It is not too much, but you see there is a reflux. And
No,
this-
there is, it's long.
Yes, it is not too much, but there is a reflux. So sometimes you see varicose veins.
It's more than 1 second, Erika.
Yes, now far more than 1 second, two and a half. So sometimes this
Yep.
will help you to discern between very, very slow refluxes. So then I turn around. I don't want to do the complete exploration because I have 3 more patients to show you. The right leg is the correct, the healthy one. So I just show the photocopetia. I usually make a longitudinal scan of it. Then I put the color just to make sure that everything is fine. Again here, sorry. The vein seems blue. It's normally contoured. There is no issues. Always, please do not forget to have a look on the compression. This image is very important in the records. And you have to once check orientatively the flow in the artery. Because if you have no good flow here, you have to think about compression. I know that this is not the correct way to investigate arteries, but you have a good three-dimensional, why is it inverted? Yeah. Okay, a three-dimensional flow, three pulse flow in the artery, and so we are happy with this. Now we have the Giacomini.
The vein is compressible. You can see the vein and the small softness. You can see it.
And this is the thigh extension of Giacomini vein because I'm going up, as you see, I'm going up from the knee fold.
Yeah.
And I measure there. It's always, don't forget to measure inside the Giacomini vein. but this is okay. And then you go down.
Erika, there is a question. Erika, I beg your pardon. There is a question in the Q&A box about the provocative maneuver. Maybe if it's now you can do some of the provocation or provocative maneuvers.
Yes, we will do them all in.
So what you are doing is a
Yes, I can't hear.
Yeah.
That we are having a few different sounds here in the room, okay? So I have some provocation maneuvers. The classical one everybody does is compression and release. Yes? We'll do it on a deep vein because there is better to be seen. Compression, release. So another one can be toe elevation. Jedes Mal jetzt hier und runter. Und nochmal einmal hoch und runter. So, toe elevation und runter. No, we didn't do it properly. Einmal hoch, einmal runter. Perfect. So this was the toe elevation movement, and this was the release, the back to round movement. These both maneuvers are those I do the most often. If I'm not happy with my flow, I do the dependency maneuver, laying down the patient, and very, very seldomly I do a salva. Why? Because if I always investigate in standing position, and if people keep doing Valsalva, they faint. So I do very seldom with Valsalva. I don't like it because people tend not to do it properly, and you often have movements and so on. So we have here an interesting thing because we have a perforating vein. How to discover a perforating vein? This is the fascia, the saphenous fascia, the muscle fascia, the saphenous compartment. And here a tributary goes out of the saphenous vein, and we have to have a look what's the fate of the vein. So it is going.
you can see the saphenous ligament also. Could you
Yes.
put on the saphenous ligament the echogenic line between the two veins? Yeah, very well defined.
Yes.
Perfect.
And here you see that the tributary is piercing the muscle fascia. So this is a perforating vein. If it would pierce this one, it would be a tributary. But as it goes down inside the leg, it's a perforating. And now we have a look on the flow. First with compression, nothing happens. Jedes Mal jetzt hier und runter. In der Diastole jetzt nochmal einmal heben und einmal runter und nichts mehr tun. In the diastole, nothing happens. When you moved up the toe, blood was flowing, but when you release it down to the floor, nothing more happens. So this perforating vein can be defined as healthy. And we will find better ones to investigate. So now
Erika, could you please, when you put the color box, could you please explain a bit by the direction of the flow on the color scale on the screen? Put the color flow, please, because a lot of us, they don't know about the direction from the color mapping.
Okay. So now we go to the left leg, which was the one the patient was consulting me with. And if you have a look at this, I will make a split screen.
Yeah.
Just to remember, this was the right side, and this is the left side. You just see that there is a difference in the diameters of the Giacomini vein. And if you go down, you see lots of veins here, and you'll see one thing, a very large subfascial vein. This is the muscle vein pair, the artery, and then now we have this color back. And this is what Vascular was telling us.
Yes, please.
You have to be very aware that this upper part is red and the lower part is blue. Because if you make the change like this, and you remember that the blood flow in ultrasound is defined as blue is away from the probe and red is going to the probe, you will have the wrong results. So by definition, when you investigate vessels, it has to be the upper part has to be the red one, and the lower part has to be the blue one. And so in veins, we expect when we explore them, that we have mostly blue flows because the flow is going from superficial to deep and from down to upstairs. So if I compress, we see something here in these veins, which should not be expected. Have a look at these veins. They should be blue, but they are red. This is because he had thrombosis and the valves in these veins do not close properly. So let us have a longitudinal view. We can do this a little bit. A longitudinal view, and we see there is in systole an anterograde flow in the popliteal vein, in the Giacomini vein, and when we go here, you see where the muscle vein starts, and you see in the muscle vein we have a reflux after decompression. Geben Sie mal die Zähne einmal hoch und runter, which is better to be seen after elevating the toe. Yes, this is
Could we try with the Doppler, pulse Doppler to come? Yes, please. Thank you.
Exhaling, elevating and down. Compression. Now we have to give the leg a little bit of time.
Yes.
We see when he moves, because he's standing, he has to correct the position. You always have like a, I say it's a pendulum flow. It goes up and down. You will have it in another place here. And here you see that the reflux in between the muscle contraction is longer than 1 second.
Erika, we have in the chat a remark. I cannot surpass it. An insonation angle, but because you put your cursor of the Doppler at 90 degree perpendicular to the vein. An insonation angle of 90 degree does not produce adequate waveforms to be studied. What you would say?
I would say that most of the time I investigate like now, where the vein is just coming out to the
This is from Wadi Nito. No.
Oh, this,
yes,
in
Wadi
case,
Nito.
In this case, we have the vein perpendicular to the probe. Yes, to the probe measurement point. Wait here. This is the vein, and the measurement is measuring in this direction. So let me just finish this place, and I can explain you the next place.
Okay.
Here we have.
I question what kind of ultrasound brand. This is a GE, I can say. We can see at the left, very most left. Yes, GE. It's a GE machine.
But now just have a look at. This is a very important place of investigation. This is a perforating vein between deep veins and the Giacomini vein, and you see that there is a long-lasting, starting here 1, 2, 3 seconds, and I stop the screen. You can do it again. Geben Sie mal die Zähne und runterlassen. We wait and wait, and it runs and runs and flows and flows and flows. This is a real long-lasting reflux in diastole. You see this refluxing because it is above the line, and it is after he has moved, so in diastole. So now I come back. If I make a longitudinal investigation, yes, like here, if I measure in this vein, of course, I should correct the angle. But to tell you the truth, we are not investigating arteries. It is not about the flow velocity. It is just
Erika, so you are putting now the color boxes. So we have a question, very interesting, from Erwin Tunder. He doesn't need any introduction, from Netherlands, about the scale of your color, scale PRF high. I think with the color you have 16. I think so. You have 16. This is Erwin. This is not me. This is Erwin Tunder.
So I was trying to explain that when I measure here in longitudinal view, it is only a semi-quantitative information about the flow because we can't, the saphenous veins are parallel to the skin. You will never, with inclination of nothing, find a probe inclination so that you can never incise the vein parallel to the vein walls like you are supposed to do in arteries. This is why I love to do it like this and tilting the probe, where you have a far better flow measurement. But the thing in veins is not about the highness and the velocity, but on the duration of the reflux. And this is the same even if the probe angulation is not the perfect one. So now we go back to Erwin Tonner. Hi, Erwin.
Now you are in a 15 or 16, 15 centimeter per second. Could you play with your velocity, color velocity scale, put it down a low scale,
As normally I use
and to see if the you will get much more sensitive imaging? You are on 15 now, Eric.
Yes.
Could you put down your velocity scale?
Let me try and answer you. So normally I have 15, yes, and here we see this perforating vein flowing outside. If I play with the PRF,
Yeah.
and go up to 45, 60, yes. And the
Now we lost everything. With 100, we lost everything.
It's gone.
Yeah.
Yes, no longer a reflux. Not in PW, not in color. So we go down with the PRF again, go down to 64. We have a little bit of it.
Yes.
We go down to 18.
18 now, yeah.
See that the curve is adapted to the better the framing, the pulse repetition frequency. So this is the correct one. You have to have a low one to measure veins, because if you have a too high pulse repetition frequency, you will not get the information you need. So coming back to the leg of the patients, here we have the Giacomini vein, which is enlarged, is long standing here. Here there was a thrombotic saphenous saphenous vein thrombosis when he had his muscle vein thrombosis. So this is a little bit of not normal anatomy. We are trying to find the saphenopopliteal junction. It could be this. It could be this one. Yes, but it is difficult to do because the anatomy is changed through the thrombosis. Alles okay by you?
Yeah.
Perfect. The patient is feeling well. And so now let's have a look. Let's check the small saphenous vein at this level. You see my probe is tilted, and you see the small saphenous vein is competent at this level. I go up and up and up a little bit. Here I wouldn't say which one is the small saphenous vein. I couldn't explain. So we have to think about what happened to the blood, to the reflux. We had a perforating vein here, filling the junction here. That was our perforating vein. It fills the Giacomini vein. We go down. And this one we should define as the saphenopopliteal junction. We can just have a look on the flow here inside.
Erika, there is an interesting question from Attila Puskas.
Hi,
I hope I pronounced well the name. When you place the sample for your pulse Doppler to test the perforator flow in diastole, which is the right place to put it? At the muscular fascial level? This is the question.
Yes.
So could you demonstrate where you put your cursor?
Okay, let's come to that. We have the small saphenous vein here, a tributary. This one. You follow the tributary and you see here it pierces the fascia. Yes? So let us have a look where, and I'm sure I have to start with color because the change of the angle is better in the color. So I start with color. And you see now, we will make the mistake. If you see now, you think that there is, no, my explanation doesn't work. Yes, you could imagine that here is an anterograde flow because there is a blue flow. But if you then contrast it with this
Yes.
scale here,
Yes.
you see the scale is erroneous. You have to invert it. You have to invert it and have the red one on top. So now I put the PW and I show you exactly. You have to measure the perforating vein on the place where it pierces the fascia. So again, patient is standing and moving a little bit. So it is difficult to decide if it's going in or out. Now I make a calf compression and release. And you see that for a moment, this was the calf compression release, and then it is an outflow. So this is an obvious refluxing perforating vein. And the best place, like here, you have to find somewhere where it goes perpendicularly to the skin and pierces the muscle fascia. You can't see, but the patient is always moving a little bit, like with equilibrium problems. So we will make something that's yeah. We will try to have him sitting down, so we will not be moving the calf muscles. And I will try to find the vein from behind, the perforating vein, on the relaxed leg. Here you see very, very well scars from the old superficial vein thrombosis. You see this? The vein has
Yes, we can.
Yes. Here is scars from the old thrombosis.
It's there is a remnant of the old phlebitic changes of the vein. Could you put it again, please, Eric?
And do it. Here.
Yes, because this is very important. Yeah, we can see it now.
Yes, here you see there is something crossing like the vein. I will put another. Here you see material inside the vein. Here, yes, and this is like little scars. Here you see very well. This one is a little scar.
Yes,
old thrombotic change in the vein.
If you put the color, it will be like a double channel here.
That's the color. Here, this is superficial still. I lost the place.
Yeah.
There.
Yeah. We can see it now. Yeah.
Okay, and now I want you to try and find the perforating vein. And then we have to release this patient. He has to work. He left all these people waiting for him just to come here. Where is the perforating vein? Maybe on the other side? You know, I'm not used to make the ultrasound in 16 persons. There. And there. It's also interesting when the guy is sitting, the perforating vein is much larger. You see that? And I can't, like here it is.
Yes,
here
we can see now. Yeah. Could you put your color box may be much longer, so the rectangle less wide but longer than this, so you can get all the perforator in the same image.
Just a second. Give me a second.
Mm.
Not quicker than me. So in this case, it is less volume moving, and you see when I press, it goes inside, and when I release, it goes out. Yes, this is classical determinant for and now I change the color box.
Yeah.
Let's just change the place. Like here, and the perforating vein has kind of horizontal flow. It doesn't go to the depth; it goes like horizontally in the. We will have another cases with other perforating veins today. I think we can release the guy. Thank you so much.
We would like to thank your patience. We can applaud her. Thank you so much.
Okay, thank
Erika,
you.
we have a great question from Ashish from India, the big figure of CLACS. Professor Erika, in what percentage of patients in your practice do you come across a diastolic refluxing perforator with deep system patent and the saphenofemoral junction competent, being so responsible for the superficial vein reflux?
So if we say the deep vein is competent, it is less than 1%.
Less than 1%.
He had a reflux of the deep vein. This is why he had a refluxive perforating vein. But normally you have only draining perforating veins. It's very seldom to find. But we will have later on a lady with a reflux from the perforating of the time. And she is refluxing as the source. There's the perforating vein as the source. Just give me a second.
Oh, all right, but thank you, Erika. I wish to say that really the perforator veins, we are in another era with the advanced ultrasound skills like we see now Professor Erika Mendoza. It have changed all our practice. But I would say that after the Dutch SEPS trial, there is no more room for the management of perforator like before the Dutch SEPS trial. So this is what a prospective, a randomized, a multi-center trial with, I would say 200 limbs with 2 arms with the SEPS, so the surgical arm and just the compression arm. And there was no big difference or significant difference, I mean, between the 2 arms. And since then, with of course the duplex guided procedures comes in our practice early in this century, 2000 something. So it makes all the difference nowadays, especially with our devastating patients with the ulcerations, with the venous leg ulcers. It has changed a lot with the guided procedures. And of course, with the room of compression nowadays, but it's we still have to for more and more. I would say research, maybe with the idea of SAPS versus compression. Maybe these days we can do the foam guided ultrasound foam sclerotherapy around the ulcers versus compression in different arms, and we have our ongoing in Egypt with the multinational in several universities in Egypt with such ideas. So foam guided ultrasound foam sclerotherapy plus compression, of course, versus another arm compression only. And we are waiting for the results. And I would say this is going to be a great breakthrough or a turning point in our practice. So we're waiting for this. Thank you, Erika, for such an excellent demonstration. And now we shall go for your next patient.
Yes, yes.
Okay.
Mr. Pfeiffer, we have, this should be just a small presentation about mesenchymal spinal osteosis. An welchen Bayern
So your patient with socks, this is okay for you?
Sorry?
Yeah.
So I will display the left grades of the
Okay.
we can go back on the different provocation maneuvers. We start here in the groin. Yeah. You see the valgus here very well. Going down.
You can see it.
I will make it longitudinal.
The valve, yeah.
This one is the epigastric vein. This one is the great saphenous vein.
Yeah.
And let me find. And this, you don't see
it looks like a focal dilatation of the great saphenous. What do you think?
Yes, it has a focal dilatation in the groin.
Could you measure this focal dilation?
I can do it.
To see how we measure the vein?
Yes, but Vascular, the topic today is perforating veins, and I'm running really low. Yeah. Everybody has so much time. This is 11.4 millimeters, which is
1.1.
enlarged. We can make another session about where to measure veins. This is a very interesting topic.
All right, perfect. We try to benefit from your skills as much as we can, Eric.
Yeah, I know. So we have a longitude, we will measure the flow. First with manual compression. You see something interesting? The reflux comes behind the two terminal valves, So I will make the image a little bit larger. We redo the thing.
Yes.
This is the deep vein, the femoral vein. This is the epigastric vein, and this is
the great softness.
Make compression. Geben Sie mal jetzt hier am Fuß und runterlassen. So I was moving, but when he elevated the toe, he had a systolic inflow. Yes? And then he lowered the toe, and we had a diastolic flow from the epigastric vein. We will work that out to the great saphenous vein, but not from the deep vein. We will repeat this.
From the coveted.
And this is how to evaluate the pre-terminal and pre-terminal valve. So we again have to make this. I will stay perpendicular, horizontal. Heben Sie nochmal die Zehe bitte an und runterlassen. Nur die. Also, genau. Und repeat nochmal die Zehe heben und runterlassen. So we have the impression that there is no real good reflux at that place. And this is why I have this patient here today. Legen Sie sich mal einmal hin. Because my most beloved maneuver is having the patient einmal das linke Bein in die Luft. And in this case, we will see a long lasting reflux. We will see, wait. 10 seconds, please. No, sprechen Sie Englisch?
Leider nicht.
Okay. Russisch, you can talk Russian to us, but not English. We go back to the place, and then you see this the following. You have we have a long lasting flow. Yes, a real enormous amount of flow. I take the PV out, and with the color we will see where the flow comes from. It comes from the epigastric, and it comes from the pudendal. Yes, and there the pudendal. And here the deep vein, the terminal valve is competent. Yes, it is just flowing around the terminal valve. This was what I wanted to show you in the drawing. And now we have to have a look where the reflux goes back to the deep vein. So we go down the saphenous eye. Everybody knows it already. We have a reflux here.
Very prolonged, yes. Very prolonged, very significant reflux, yeah.
Yes. We have a tributary. This is the difference between the perforating vein. The perforating vein would pierce this fascia, and the tributary pierces the superficial fascia, this one, or the fascia saphenous.
Very important point, because sometimes the operator, they got confused between the what pierces the superficial fascia and what pierces the deep fascia. So yes. This is a tributary. This is not a perforator. We have to make it highlighted, please.
And now we go down the saphenous vein and look for drainage points. And you see, in this case, he has drains and drains always to the tributaries. I go up again. Go up. We see no perforating veins here, no significant ones. Here is a tributary. So jetzt geben Sie nochmal die Zehe und unten lassen. And as the patient is standing again at time, the reflux seems to have been lost. Yes? But there is reflux. When we put him down again and standing, here we still have a significant nochmal Zehe nehmen und runter. Perfect. Und dann hin. Zehe nehmen und runter. So, it looks like the reflux goes out the saphenous vein here, and below we do not have any reflux any longer. I will go down the vein, down. Sometimes reflux comes back into the vein, and here this is what I wanted to show you.
Perforator, yeah.
It's a little perforating vein paratibial, MRCS und runterlassen, and it is draining one. And also you have a little artery here. There, you have always perforating veins have arteries next to them. This is why it is so perilous to make post-therapy of the perforating vein in the channel of the perforating vein, because you could puncture the artery. But this is a very, very tiny perforating vein, draining a healthy segment of the saphenous vein. Here we have another perforating vein. And you see it pierces the fascia here. So let us have a look at the wrong direction. So, einmal die Zähne heben und runterlassen. And this one is draining. This is very well seen. You see this blue, this is draining. And if we apply the pulse wave, nochmal die Zähne heben und runterlassen. As it is so thin, it is sometimes a little bit complicated to have the have it displayed in PW, but in the color it was very obvious. Nochmal die Zähne heben und runterlassen. You see it is draining in there. Stellen Sie mal ein bisschen nach klar. You see here, yeah, perfect. Here there are tributaries. And the nearer you come to the ankle, the more difficult it is to find where the drain really, because it is so difficult to put the probe horizontally on the skin. Let me have a look. Sometimes there is a perforating vein lateral, but it looks like only tributary going down. Okay. So
Erika, we cannot see the perforator vein.
No, there is no. Yes, the perforator vein is here at the ankle. He drains to the foot vein here. He goes down, and here at the foot sometimes you don't here you have it. You don't see the perforating vein so properly. Geben Sie mal die Zehe an und runterlassen.
And what if you can lower the velocity scale? You have 17 now. If we try to lower a bit, yes, 15,
Yes.
12,
Okay.
now 10 now, yeah.
Here is the vein going down here. But sometimes if you put it, it's really difficult to
Yeah.
find. But I'm going to see again und runterlassen. This one could be a perforating. There, yes, you see it goes in. Can you show you have the vein just going down here and it drains like below the foot. I will go there. Tell you the truth, this is didactic because normally in clinics it is completely if you treat the varicose vein, this one will disappear. So I don't normally investigate slowly. There is one. There you have the tributary and the subfascial vein.
Yeah.
And here it goes in.
Yes, we can see it now, yeah.
Yes.
Because the compartment here between the posterior tibial veins at this level is very shallow, so the perforator
Yes.
itself is very short, it's very small one, yeah, absolutely.
So this one was non-axial reflux, and I wanted to present the patient because of the maneuver. Yes, that you saw that there is little reflux in all the maneuvers, but in lying down and standing, there is really a large reflux. So this was what I wanted to show in this patient. That's fast, yeah. It was a quick presentation. Would we please make more questions now? One
In the
more.
call? We go for the second poll, please. Now the second poll, which answer is correct? And just single choice. Number 1, dilated perforating veins have to be interrupted. Number 2, refluxing perforating veins have to be treated. And number 3, dilated perforating veins with draining flow in diastole reduce their diameter after interruption of the reflux source.
I hope everybody comments correctly.
Excellent demonstration, Erica.
Thank you.
And this is a good example for Shiva. I would say this is the operator skills. Because we can see that at the junction, it was purely comes from the JSV, and we have a big refluxing tributary. So if you can do it really, Shiva technique, it will be fine. What do you think?
Yes, I would interrupt the both tributaries and the groin in the thigh and leave the groin untouched.
Yeah.
Because the terminal valve will preserve the reflux. This is a real
And
good.
if we put a scenario that a patient with such a perforator at the distal leg level with venous leg ulcers, what would be your treatment? Because we have a question about the treatment of the patient. But in cases much more advanced, I mean, in C4, C5, C6, what would be your...
He had a little bit of visible veins, but no edema. So he's a patient with me already for 5 years, and he has no compliance. So we are not treating him. You could do 2 things in my eyes. You could close the great saphenous vein below the junction to allow the epigastric reflux draining to the deep vein, like you do when you do laser. Yes, and I would only ablate the proximal segment of the great saphenous vein, or you could do a tributary interruption. Both large tributaries at the proximal thigh. If you interrupt them surgically, you can expect that the flow in the great saphenous vein will revert in over 90% of the cases. Yeah.
We have the results of the second poll with the 63%, again with the third answer, that the dilated perforating veins with draining flow in diastole reduce their diameter after interruption of the reflux source. There is some question about the technique, Erica, how to make the ultrasound window larger and the window with the moderator smaller. This is very simple. With the button on your machine, you can adjust your color box very, very easily. Once you know the button of the set, and you change the color box upon your, you see how you will see your vein better. This is very, very, very easy. So with your application specialist, just one session with your application specialist, you will know, you will understand every button, what is the function of every button, the color, the gain, the velocity scale of the color, with the depth, with the beam mode, with the Doppler spectrum, with the velocity scale. Everything will be very easy with just one session with your application specialist of your machine. It's not a big deal, don't worry. Ultrasound, it's really an amazing modality. This is our eye. We see the patient from inside by the ultrasound. This is it's a beautiful modality, really, diagnostic beautiful modality. So now again with the please.
Yes, we have a male patient, and you have varicose veins here, but again, not very good. So here there are some varicose veins, and if you touch, he's very still. You can touch the great saphenous vein here because there is really no fat. And some, yes, continue. So he came just to have a look, but without complaints. So we are also thought we would damage a little bit. I will show you the classical investigation of the great saphenous vein coming from the groin. We have artery, a little lymph node. Compression, perfect, everything is fine. I tilt a little bit, and there comes the junction.
Yep.
great saphenous vein. We have tributaries of the junction. We have a lot of longitudinal flow. And what did you see? Everybody of you, you are so trained. You say, the vein is very tiny. Coming back to Vasilas asking from
Yeah.
minutes before.
This could be an accessory saphenous vein.
This is 3.4.
Anterior. Now there is no accessory. Anterior saphenous vein.
This is the anterior accessory saphenous vein is this one.
There is no accessory by the recent publication. Suad Dogenji and Professor Alberto Caggiazzi, they eliminate now the word accessory. It's anterior saphenous vein.
Okay.
All right.
Sorry, I didn't know that. It will take some years for me already.
Very, very, very nice to see it. Thank you, Erica, because it's a very important round, very important.
So, and this one is a very healthy vein. And you ask yourself, why would I touch it on the thigh when there is no reflux? Einmal. Gucken wir auf meinen Fuß, dann muss ich durch und wieder runter, aber dann bin ich da. It's so tiny that I lost it. So we go back there. Am I there? So it looks like healthy, but we have learned that that doesn't work. So legen Sie einmal mit. Und machen wir das linke Bein in die Luft. Kurz ab ins Weg.
It's an amazing maneuver. It has a name, this maneuver, Erica?
If it has a name, it is called dependency maneuver. Or what was the question? I didn't know. Was that the question?
The maneuver itself. So when you have a small vein,
yes,
and you don't have any reflux on standing position, then you ask your patient to lying down, to raise the leg, and repeat it again with the same level. This maneuver, I like it very much. It has a name, Mendoza maybe.
Oh, no, dependency maneuver. The Mendoza maneuver should be the toe elevation. I published that in 2000, but I called it Wunstorfer maneuver. And this one, I published it only in German. And same month, it was published by Chris Latimer in English. So we had two stupid purple persons, the same idea, I always say. We had the same idea at the same time, and it is in English, the name is dependency maneuver.
Right.
Yeah. And now we go back on the great saphenous vein, which is so tiny, you can find there it is, no reflux. Because, believe me or not, it is healthy. This vein is healthy. So we go down, and look what happens if we go down on the great saphenous vein, which is really, really tiny. You see here the fascia, perfect. And what is this? What is this? Attention. What is this? You have a perforating vein. First, you have a tributary piercing the fascia saphenous, and then you have a perforating vein piercing the muscle. And we go and put color in it, and you see, there is still, from the dependency maneuver, we still have a flow there. The perforating vein, which is flowing and flowing, the tributary, flowing. And this is for the intelligent ones between us, which is everybody. Einmal heben bitte und drücken lassen. You see there is a flow, but what is alarming in this flow? It is a diastolic flow. This one is the diastolic flow. What happens with the direction? It is a diastolic flow in the correct direction. So what happened in this leg, and this is why I brought it to you. I do a longitudinal representation of the vein. Sometimes it's not as easy. And I come from above. This one is the tiny gray saphenous vein. I go down and find the tributary here, leading the saphenous fascia, and the great saphenous vein on parallel, and I will do the color. Attention, color. You have
Yeah.
in diastolic an ascending flow in the great saphenous and a descending flow in the tributary. And why is this like this? Because here you have the conjunction of the, I have to go to cross-section because it's easier in this case. Great saphenous vein, tributary. The tributary comes in the great saphenous vein at this level, and the perforator, sorry, and the tributary is leading here. And between this point and this point, we have a diastolic reflux, but it is going upstairs. So it comes out here, it goes up here, and it goes draining through the perforating vein. Is that clear to everybody? I go.
This is, you mean it's a closed circuit,
It's a
superficial to the superficial?
Yes, we have here, we have the, I go back to the vertical. We have the deep vein and the perforator coming outside, draining, filling, refluxing, and
Yes.
filling the great saphenous vein, but not as expected, filling it downstairs, but it is filled, and this short segment has a diastolic flow, which is pathological, but goes up because the draining tributary is a little bit higher. I will paint it on a paper. Just a second, it was 5 meters.
Perfect.
I want paper here. Yes, I have one.
Arita, there is an interesting question from Professor Lowell Kabnik about when you use the maneuver, Valsalva maneuver.
Nearly never.
So when you have your patient on standing position, do you ask him to do Valsalva, or you prefer when he is or she is lying down? Because repeated Valsalva maneuver can make the patient some dizziness or drowsy. What do you think?
So, Valsalva is depending on so many factors. The patient is to do it in standing position, you can't repeat it, and so on. And as you have seen, I was able to show you all the refluxes in situations with combination of manual compression of the calf, with toe elevation, and with the dependency maneuver. So I don't see the point to make Valsalva. And I'm so sorry for all the very, very good intentioned old books writing about Valsalva. Valsalva was relevant when you investigated veins in recumbent position. Because you don't have the gravity to help you in the reflux. But as long as you make the investigation in standing position, you don't need it. And sometimes, if I really investigate deep veins in the groin or iliac deep veins, I make a Valsalva when the patient is laying down. And I do it in the following way. I put my hand on the stomach and I say, press your belly against my hand. Then they try to put out the belly, and so the reflux is there or not. Because if you tell them to inhale, don't exhale, press, they either exhale or they do whatever they want. And so really, Valsalva is very seldom in my case. So now I want to paint here. Would you address this? Do you see this painting here? I think you have to go nearer. So like this, yes. Yes, okay. So this is a deep vein in this patient. It goes upstairs. It's perfect. This is the terminal and preterminal valve region. Blood is going up. And you have a perforating vein bringing the blood outside. And it comes to the great saphenous vein. And instead of going down as we are used to, it goes a little bit up. The reflux goes upstairs and then goes into the tributary. So you have a small dilated segment of the great saphenous vein which is flowing up. And if we come to the question how to treat this patient, it would be enough to close here. Because what he sees on the left, yes, is this tributary. This vein has such good valves, the great saphenous vein has so good valves that the reflux coming from the deep vein didn't manage to make the great saphenous vein incompetent. Yes, we have a perforating vein, and when we close this one, the flow will go up here. So even we don't have to close the perforating vein because we have a circuit that will drain upstairs. Yes, and this is a very seldom situation. This is why I presented to you that you have great saphenous vein dilated with diastolic flow, but in the correct direction. Is this clear, Vascular?
Can we put it much more highlighted because we cannot see in the diagram? I can say instead the screen of the ultrasound, could we put the schematic diagram on this
Can we put
camera? Because it's very interesting what you are saying now. It's very interesting, but we cannot see it clearly, the schematic diagram.
Can you please print the screen of the mobile?
So the main image is the ultrasound screen. Huh? So if we can change it with the diagram, it will be great.
Maybe you can stop sharing Khaled and then put my mobile screen as a pen.
Okay. Or perhaps we have another perforating vein of the lady. Oh, yes. Okay, perfect. So here, now it is better, yes?
Now it's better, yeah, but it's not the single image. If you can make it larger.
I made it again, and so it will be better understandable.
Yeah.
I made it again. So we have a deep vein going to the heart. Yes, a heart for everybody doing phlebology. Okay? Then we have the junction, saphenous femoral junction, with the great saphenous vein. The blood flow in this vein is orthograde, antegrade. The blood flow in the junction is antegrade. We have a tributary, which is refluxing. Yes? And we have to know where this reflux comes from, and the GSV is competent here. And we expect a perforating vein, for example, here. This is a typical case, going out here, going down here, going down here. But in this case, we have a seldom situation that the perforating vein is below the tributary. So we have the reflux from the deep vein, we have the dilated, the complete great saphenous vein has an antegrade flow. So it would be a pity to destroy it anyway. Interrupting this one here, you will have the clinical result that this vein will disappear. You may, after interruption, you may make a phlebectomy, whatever you want with this vein. And if you leave the perforating vein, you will have the situation that the flow coming out here will go upstairs and drain to the deep vein again. So even if this is a
It seems that some people, they cannot get the image till now. I had a lot of not able to get the image. You are only seeing the modified MOH screen.
Yeah, but in this
It's
case,
still not
you need to
visible.
change the view. If you cannot see the screen, change the view and it shows the pen screen. As the Zoom platform, you can change what kind of view. Is it the all speakers or the pen screen? If you are using mobile, you can just select switch screen. If you are using the computer, then you can use to bend the screen that you want. Is actually putting the mouth here.
So now,
Oh,
I will paint it there.
now they can see it.
محمود هو ليه مش عارف تجيب السكرين بتاعتك هي تبقى الكبيرة؟
I have two mics on. Vasila, do you hear me?
Ah, yes,
I
I
will
can hear you. Yeah.
I will do something else. I will take a Word. This is a Word document. Please do not look at what is there. I will open an empty one and I will paint what I painted there. Just have just a moment. This is the deep vein. No, sorry, I could have made the arrow. Oh, sorry. So, you are seeing the wrong thing. Sorry, I will do it again. This one. Okay. We have the deep vein. Sorry, I'm not so good in painting.
No,
This
perfect.
thing. Yes, we have the
Yeah,
great
we can see it.
vein.
Yeah, that's
Yes.
perfect. That's better. Yeah, thank you, Eric.
Now we have the anterograde flow in the great saphenous vein. We have the refluxing tributary, which is refluxing, really refluxing. Yes.
Yeah.
And we have the perforating vein, which is also refluxing. Yes.
Yes.
And we have the strange, it is not very often situation that this segment of the great saphenous vein has a diastolic flow, but it is anterograde. So we have a reflux in this perforating vein. The reflux goes anterograde upstairs and then retrograde through the tributary. And he has just told me that he went to a clinic nearby. They love to strip veins, even though the veins are healthy. And they have recommended him to make a stripping of the great saphenous vein from the ankle to the groin, because it brings far more money than making this interruption here. Because if you take out this connection, the flow from the deep vein may continue going outside here, but it will be anterograde, draining again to the deep vein, because obviously this great saphenous vein has so competent valves that the reflux from the deep vein was not able to revert the flow here. Normally we expect that we would have a reflux here, but this didn't happen. Yes, this reflux didn't happen in the leg. So he has a very, very healthy great saphenous vein overloaded by a perforating vein, giving this overflow to proximal tributary and then being again healthy. This is for me, very interesting situation. This is why I wanted to share it. But now the image has been clearly seen, yes?
Thank you, Erica. It's very interesting because this is our really daily life practice. But
Yes.
I wish to ask you about the treatment in this case. What you would like to do for this patient if she has a tributary incompetence that comes from the perforator, the reflux comes from.
Yes.
What would be your treatment for such scenario?
As I picked it here, I'm not treating him because he has no complaints.
No complaint. So no
He has
treatment.
no problems. So he is coming to my office yearly since 4 years. The tributary is not getting longer. He has no edema. He has no discoloration. Why should I treat him? The only thing I know when I treat him is that he will have a recurrence by 50% of cases after 5 to 10 years. I have one more patient. Yes?
So
But-
you do diagnostic treatment in the same session.
You know,
With your
I-
probe, she has no science, no anything, no complaint. That's really great.
No,
Can I
no.
ask, she has on compression therapy?
Yes, he is
compression
on carb compression therapy. He is an asymptomatic C2 patient.
All right.
But if he was symptomatic, or if he asked me to treat him, I would start just like I picked it here. I would start disconnecting the tributary from the great saphenous vein. Even you can do it with a foam sclerotherapy. You can do it with a surgical disconnection. You can do phlebectomies, whatever you, but not touching the great saphenous vein, which is completely healthy. If the perforating,
yes.
yes, if the perforating,
I would say for the foam, sometimes we cannot really control where it will go. Sometimes in this scenario in particular, some of the foam can go easily, go
Yes,
to the GSB
because
or to
this
the
is-
perforator. What will be your tips and tricks here? Yeah.
this is why I wouldn't select foam sclerotherapy in the first point, but if you think of it, always when you make foam sclerotherapy of the great saphenous vein, you will have inflow of foam into the deep vein, and nobody bothers what will happen with the deep vein because the foam sclerotherapy, as soon as it gets in touch with blood, it will be no effective. So I would expect the same here, but personally, I would prefer to do a surgical little incision here and disconnect, a flush disconnection of the tributary at the level of the great saphenous vein. And then I would wait what happens with this. And I can tell you by 27 years of experience, it will be still refluxing, the perforating vein. The blood will go upstairs and drain to the deep vein, and nobody will bother with him, with the blood, excepting for eventually a new tributary will form. Yes? But closing tributaries is very difficult because you have to make a long scar. This tributary was tortuous. You can't go inside with a good probe. So I would just say he is asymptomatic. He needs no treatment. But I know this is not very monetary good. Yes. So all the people treating for monetary reasons would not share this opinion. I'm sorry for that. Now we go to the next. The last patient. She was waiting a long time already because we have extended, but everything is fine. So I go back to my ultrasound. So now could you show we have a lady with visible spiders and here she has visible spiders. If you look at here, she has a little bit of beginning discoloration, brownish. It is not so good. Is the light on? No, light was already on. So here is a little bit of discoloration, and if I press, there is a little bit of edema at this point. So she is symptomatic. She is C2, she wears compression, and we will treat the lady the next weeks. And today she has offered us to see her leg before treatment. Yes. I start in the groin, as we have always done. Perhaps, Mahmoud, do you want to show? I have my setting. My setting in the room is, I have this where I treat the patients when I do, for example, in luminal laser therapy. There I have a second screen on the wall. So when I treat the patients, I do not have to go back with my head, but I can look straight forward. For doing sclerotherapy, I can put out or on the light to see better the veins with ultrasound without light or directly with the light. This is my personal setting. Don't destroy my office. So you have to be careful, the lady speaks English. Yes. So we have the artery, the deep vein in the groin, junction of the brachial.
Compressible, the junction, we can see it, yeah.
in a second. And we have a very interesting thing. We have a pudendal vein draining directly to the deep vein. I always say if we had the fingerprints, I could identify every person by his or her veins. So we have the compression. And now we look at the junction in longitudinal also. Upsala. Sometimes not so easy when the veins are as thin. Doctors never get happy. They say you have to not to be obese, and for ultrasound they say you are too swollen. So this is the junction place, but the vein is so thin that I can't even make a good reflux.
We cannot see the junction yet, Erika.
Oh no, wait.
Yeah, all right, we are waiting.
That is the junction, but there is no. Perhaps you can do the Vascular now.
Okay.
So, well, I hope you're okay. Einmal tief Luft holen, Luft anhalten und tief in den Bauch reinpressen.
There is no flow in the femoral. Yeah.
Weiteratmen. There was a little